Thank you to IJCP for this very interesting session. So what we're going to do in the next few minutes is going to discuss about the new definition for clinical obesity, and we'll make it like a case-based discussion. So me and Chandra sir will discuss some clinical scenarios, and that clinical scenarios will help us highlight what exactly are we, inferring by the new definition of clinical obesity. So let's take two cases. Now, this is a case of Mamta. Now, Mamta is 48 years old. Her BMI is 34 kg per meter square. She's perimenopausal and has some vasomotor symptoms of menopause. That's her main complaint. But otherwise, she's healthy. Now, she has no diabetes, no pre-diabetes, no dyslipidemia, no other organ involvement. She does because she understands that she, has BMI on the higher side. She does exercise regularly and tends to eat a healthy diet. And on the other hand, we have the case of Joginder. Now, Joginder is 58 years old, so he's 10 years older than Mamta, but his BMI is exactly the same. His BMI is 34 kg per meter square. And as you can get from the name, he's a male. His waist circumference is 112 centimeters. He's pre-diabetic and his HbA1c is 6.2%. Now, recently underwent an ultrasound where he has a fatty liver. So he presents to us mainly, and this is his main complaint, he has dyspnea on exertion with NYHA grade 2. His echo was done, which shows normal ejection fraction, but it shows diastolic dysfunction. And he's also having dyslipidemia. Now, he does tend to have a little bit of early morning headaches and some daytime somnolence. So probably what we're dealing with some sort of a sleep apnea. He says, and when we told him that, you need to exercise, Mr. Joginder, he says, I can't because I have knee joint pain. And, my weight hampers my exercise. He also has a little bit of bilateral pedal edema on examination. So these are the two cases. And at the outset, sir, Dr. Chandra, sir, what do you make of these two cases? So as you can clearly see, the BMI puts both of them in the same category. So what's your initial inference of both these cases?
See, that is the beauty when you just try to know the metabolic profile of the patient. And if I say BMI is just a number, if you don't know other part of it, because BMI doesn't tell us about what actually pathophysiology is happening. In case of Joginder, we can see the fatty liver is there, there is pre-diabetes, there is diastolic dysfunction. So somewhere or the other, we can make out from this that Mr. Joginder has got obesity-related disease or obesity-related chronic disease, whereas traditionally we used to call healthy obesity. I don't know if that definition exists now or not, but the lady probably is obese by definition of BMI, but her metabolic profile looks to be normal. She is doing regular exercises and she doesn't have any metabolic complication or disease as of now. So these two patients these two persons are quite different. One person is having obesity related chronic disease, other person is obese but doesn't have any metabolic disease. So there is a huge difference in between these two cases.
Exactly the point. So let's say, and why is this important? What is happening now is that now we are going to have a lot of medications which are going to come, which are going to be specifically for obesity. And some of these medicines like GLP-1 receptor agonists, some double triple agonists, which are going to come in the future in India. The important thing about these drugs are that they are very expensive, right? So there'll be a point of time where a lot of time, there are a lot of times, like for example, your CGHS and your certain insurance companies who tend to reimburse certain forms of treatment. So then the issue will come is that who should get priority in terms of treatment, right? Now, if you see, and this is exactly the problem which recently the Lancet Commission came up with some sort of a solution to this. And this is exactly the problem which a lot of countries which have socialized medicine really face. For example, UK, right, which has socialized medicine. So in UK, if you just go purely by BMI criteria, then both Mamta and Joginder will become eligible to get injectable semaglutide or a tirzepatide. But clearly, if I have to choose one, most likely we are going to choose Joginder because quite clearly he has complications associated with the obesity. Right? So correct. So the problem with BMI is that unfortunately it's one size fits all, quite literally. Okay, so you have both. You can see clearly from this picture. both the lady, which is Mamta, and Joginder, both of them are actually, based on the BMI, put in the same category as having obesity, right? So that is the major challenge with the current definition of defining obesity, is that without actually seeing the depths of the patient and without seeing the clinical aspects of the patient, we just, based on a number, categorize both this patient in the same group. And that's what makes it a challenging proposition, especially in the era where treatment is going to be a problem. So as you can clearly see, Mamta and Joginder are not the same, but they have the same BMI, right? They have a different clinical picture. Now, Joginder, quite clearly, sir, as you saw, has a lot of complications. So which can you just sort of elaborate which complications you envision in Joginder as a patient?
See, we often talk about obesity being the cause of different diseases.
Correct.
And there are many hypotheses about insulin resistance, inflammation, or what we call that these diseases start together. And what I could see in Joginder, all diseases related to insulin resistance is there, fatty liver is there, then dyslipidemia might be causing some impact of atherosclerosis. Patient has got diastolic dysfunction in the heart. He had just came to us with complaint of dyspnea and NYHA class 2. So what I could see that because of obesity, obstructive sleep apnea, one of the great problem, underrated problem, I would say, which is causing a lot of trouble to us. So what I could see that obesity as such has caused multiple organ dysfunction or organ compromise in Joginder, whereas in lady we could see Kamla, we could see that she didn't have any compromise. So if I had to prioritize therapy, probably Joginder is the person who really needs management of obesity on priority, so that all those pathophysiological involvement of different organs could be addressed appropriately.
Yes, absolutely, sir. So this is exactly the point. So as you can clearly see, in terms of prioritizing treatment, we probably need to prioritize the person who is having complications because of obesity. And quite clearly, we can see that though based on BMI, both the patients are the same, quite clearly one is quite different from the other, right? Now, these are the issues with BMI, right? So BMI is not a perfect marker. Now, the problem with BMI is that BMI initially, when it came, it was supposed to be a risk factor. It is a risk factor. But now we understand that obesity is not just a risk factor. It's a risk factor as well as it's a disease in itself, right? So I'll come to this differentiation in a minute. The problem with BMI is that it was originally designed to be a risk factor and not a marker of disease, right?
Correct.
And, the problem is that another issue, as you saw from Joginder, he had a, waist circumference, which was 112, which is quite high. So the fat distribution also amongst patients differ, especially Indian patients tend to have a lot of central adiposity, right? And we very well know central adiposity is linked with a lot of metabolic complications. So again, though BMI does tell us that the patient is having a certain weight threshold, it doesn't tell us what is the distribution of that weight, and hence the distribution of the weight is often a problem. Sir, you remember that famous YY paradox, right?
Yeah.
Where you had, so you have Dr. Yajnik and Yudnik, who was a Russian, a Caucasian, both had the same BMI, right? But if you did a DEXA in both of them,
22 BMI, and one had 9% fat and another had 21% fat.
Yeah, so the Indian had more fat at the same BMI, whereas the Caucasian did not. So that clearly is a difference, right? So BMI is not an ideal marker for telling us about fat distribution.
Another thing I wanted to add, if you allow me, the traditional way of talking about pear-shaped obesity and apple-shaped obesity.
Yes.
I mean, the fat, if it is in the viscera, in the abdomen, if it is apple-shaped, and if fat is distributed within the body, within the limbs. So these are, can you please elaborate about that? That would give a good idea.
So yes, absolutely. We'll come to that point as well. So you're very right. So the, the fat, which is also known as android and gynecoid forms of obesity. So generally speaking, men, because of the testosterone, tend to accumulate fat more in the abdominal region, right? And that tends to have more metabolic consequences. It tends to be more active fat, whereas women tend to have fat more in the hip and those regions, which tend to be more of subcutaneous fat. A lot of it are subcutaneous fat, and the subcutaneous fat tends to be more protective compared to the visceral fat, which is supposed to be more dangerous. I'll tell you another example, sir, if you if I may. You've all seen the sumo wrestlers from Japan, right? A lot of in the past may remember Yokozuna, who used to be a wrestler in in WWE. So these are sumo wrestlers. Now these sumo wrestlers, they started doing DEXAs of the sumo wrestlers, and they found that a lot of these sumo wrestlers had a lot of subcutaneous fat, but had very little visceral fat. So they were probably more healthy than a lot of our Indians, right? Who tend to, though may look thin, and that's a famous term, thin fat Indians, but they tend to be more obese in a sense because they tend to have more of visceral and ectopic fat. So the problem with BMI is that it does not tell us how the fat is being distributed, and it does not tell us also about the potential organ involvement because of obesity. So these are the problems. And as we discussed, the ethnic variation, right? So Indian patients or Asian patients tend to have a lower cutoff of BMI. We all have started using the lower cutoff now in terms of defining obesity in Indians. And typically, as a ballpark, 2.5 kg per meter square lower than the Caucasian cutoffs, right? That's what we, as a gross cutoff, we consider. We'll discuss the current modern definition also in India. We talked to Anup Mishra sir's paper has kind of elaborated. So there is an ethnic variation also. So do you agree, sir, with these problems with BMI? Anything you'd like to add here as well?
I do agree, because BMI really fails to tell us about the metabolic health.
Correct.
That is, BMI is just a number. It can be indicator or a risk factor, but it doesn't tell us about the exact metabolic health. So you have told everything in detail, how the distribution of fat actually is more important, and amount of fat, that is important. So BMI is just a number unless we know how it is affecting the metabolic health. Thank you.
Absolutely, sir. So that's the exact problem, right? So we discussed. Now the thing about obesity is that obesity is a risk factor, as at the same time obesity is a disease. That's what makes obesity very interesting. It in itself is a risk factor, and in itself is a disease. So we need to differentiate whenever we talk about obesity, whether I'm talking about obesity as a risk factor or whether I'm talking about obesity as a disease in itself, right? That's the key differentiation, and that is where both now there's an Indian guidelines also, and there is the Lancet Commission also. They defined obesity in two groups. They've called it preclinical obesity, which is obesity as a risk factor, which Mamta has, right? So Mamta the lady clearly has a risk factor, but she does not have any disease itself because of that. And if you take Joginder, for Joginder, obesity itself is the disease, right? So it's a risk for Joginder also. It's a risk factor for future disease like diabetes and heart disease, but obesity itself is causing a lot of problems for him, which makes it a disease in itself, right? So that's what, and Indian guidelines have called it stage 1 and stage 2 obesity. We'll come to that point in a minute. So obesity, we need to understand now in current era, is a risk factor as well as it's a disease. Okay, obesity, and it's not a new thing that it's been defined as a disease. Way back somewhere in WHO, and this I've taken this screenshot from WHO's website. WHO clearly defines now obesity as a disease. So obesity is a chronic complex disease. That is what the WHO official website says, and they also given the definition. But unfortunately, what WHO has failed is that they have given the definition based on the risk factor and not of obesity being a disease, right? So though WHO does define obesity as a disease in itself, the classical definition which they're given for obesity does not match with the fact that it's a disease, because just like we discussed, the BMI based cutoff do not make obesity a disease factor, right? It makes it a risk factor, and that is what makes the differentiation in this issue, right? Now, why is it important to differentiate between risk versus disease? And this is where the Lancet Commission very beautifully defines this in terms of this problem, sir. So as you can see, let's say there is a ditch on the road, right? Now, somebody is walking on that road. So there is a ditch on the road, but at this point of time, that person has not fallen in that ditch, right? Or fallen in that manhole. So that open manhole or open ditch is a risk factor for somebody falling into it. Whereas if somebody is walking on that road at middle of the night and falls into the ditch, then becomes a problem, right? So what was a risk becomes a problem, right? Now, the interesting thing is that the solution to both the situation is different. Okay, so if there is an open manhole or there is a ditch in the road, or there is a hole in the road, then how do you solve that problem? you solve it by covering that hole, right? Or covering that ditch or covering that manhole. But if somebody has already fallen into that ditch, what do? You try to bring that person out, right? So that's the first priority. So first bring that person out. So throw him a rope, bring the person out safely, and then also look at covering the hole later, right? So that is the clear definition. So in obesity, for Mamta, she is potentially that person walking on that road where she can fall into that ditch. But Joginder has already fallen into that ditch, right? So for Joginder, we need to bring him out and then cover the manhole. But Mamta has to be, we have to prevent her from falling into that situation, right? So I think any other, similar risk versus problem in clinical medicine, sir, you can think of?
No, I mean, the perfect example you have said.
Yeah.
I would say the thing that you have told, same thing happens with even fatty liver disease.
Correct, right? So again, yeah. So that's the thing, and again, if you see Mamta versus Joginder here, like we discussed, Mamta is having risk, right? So we tell her, okay, you're doing well, you're exercising, you should try doing that, and you are, though you have higher weight and obesity technically, you are otherwise metabolically healthy, but try to be that way. Whereas we'll tell Joginder that you need treatment, right? And that is where we need to consider therapeutic intent in these two situations, right? So that makes it. So I'll tell you some other examples. HIV and AIDS, right? So somebody is HIV positive, so it's a risk factor, but having AIDS itself is a disease, right? So that's a so somebody is HIV positive but otherwise okay, he is likely or she is likely to develop AIDS, full-blown AIDS in future, but right now they're HIV positive, so it's a risk. Same way, for example, pre-diabetes versus diabetes. So somebody has an HbA1c of 6.3. Now he or she is pre-diabetic, but somebody has an HbA1c of 12. They're clearly having diabetes. So naturally, our approach to both the patient is going to be different, right? So somebody with an HbA1c of 12, we are going to treat that patient. Somebody with HbA1c of 6.3, we are going to give them initially mainly lifestyle advice, right? Same, for example, dyslipidemia versus having atherosclerosis itself, right? So somebody has a, you do a coronary angiogram and you find that patient has multiple plaques and a significant narrowing of the coronaries. That's a disease, right? But somebody has an LDL of 160, 170. That's a risk factor, right? So patient does not have, CT calcium score is 0, but patient has an LDL of 170. So yes, we reduce the LDL, but at the same time, he does not have disease at this moment. We are just preventing the patient from having the disease. So that's a difference between the two situations.
So if I could correlate it
Yes,
with
sir.
obesity, as such, adiposity or presence of fat, we will consider it as a risk factor. And if it is affecting having some metabolic disorder like type 2 diabetes, cardiovascular disease, or fatty liver, then it becomes a disease. I mean, this is the way we can correlate.
Exactly. So that is what the guidelines are also. The newer Lancet Commission in terms of definition is also saying.
Okay.
So what Lancet Commission has done, they've defined these two groups as clinical obesity and preclinical obesity, just like diabetes and pre-diabetes, right? So that's a way. But they have given a very clear definition of what should you call it as clinical obesity and what should you call as a preclinical obesity.
Okay.
So it requires 3 criteria. So there's 3 clinical criteria that you have to fulfill. One is the patient should have BMI criteria for obesity, which is certain. Okay, that's standard as we always do. But there should be one addition. BMI of 30, right? So that's so. Secondly, what they said is there should be additional criteria, which defines additional criteria which is fulfilled. Which could be anything, but it has to be something to do with adiposity. For example, increased waist circumference or waist to hip ratio, or we'll discuss all of these points. Body roundness index or anything. So something that adds value to the fact that the patient has central adiposity, right? Third thing they've said as a criteria is that the patient should have any sign or symptom of organ dysfunction. So there should be either signs and symptoms, or there should be some limitation of daily activity because of his obesity, or there should be some complications. For example, very rightly said you, sir, that the patient, for example, Joginder, he had difficulty, he had dyspnea on exertion. So there is some amount of limitation of activity. He could not walk because of the knee joint pain. So there is directly because of obesity, he had some limitations of daily activities. And then clearly he had signs and symptoms because of obesity related organ dysfunction, like for example, sleep apnea or fatty liver and other things, right? So when do you say a patient is having clinical obesity? When all the 3 criteria is fulfilled. So BMI more than 30, patient has additional criteria for central adiposity and organ-related dysfunction. Whereas preclinical obesity is when just the BMI criteria plus minus the central adiposity criteria is fulfilled, but does not have any organ-related dysfunction, and that's what makes the patient as having preclinical obesity. So that's the definition what they're trying to do. So they are saying that just based on BMI, don't categorize your patient. You categorize your patient based on three things, and that is how they have defined obesity. Sir, any comments on this for the new?
Perfect. I would say wonderfully explained. All obese are not clinically obese.
Correct.
They are preclinical. BMI is the primary cutoff which we have to consider. Well, BMI definition, I believe you are going to explain.
Yes.
For
Yes,
Indians,
so
it is going to be different.
We'll discuss the Indian cutoff. Correct.
Yes, then BMI should have a fat as the composition. So either waist hip ratio or waist circumference ratio, or you can know some DEXA scans are also there, which tells us about the quantity of fat. So some way or the other, you are documenting that person has extra fat. That becomes preclinical obesity. And when it comes with some clinical manifestation due to involvement of some end organ, liver, heart, joints, or anything like that, it becomes clinical obesity. Wonderfully explained. Thank you. Hello.
Yeah. Sorry, I'm audible?
Yeah, you were not audible for a couple of minutes.
Yes, sir. My electricity just went off.
Okay.
So yeah. So going ahead. Yeah. So this is what the Lancet Commission really came up with in terms of the definition, and what they're saying is that again in terms of illness, there could be certain illness which are directly caused by obesity, but there are certain illnesses which are where obesity is a risk factor. For example, type 2 diabetes, obesity is a risk factor. Heart disease, obesity is a risk factor. But something like MASLD, right, or a sleep apnea, obesity can directly cause these kind of diseases in itself. So we'll come to the diseases which are specifically caused by adiposity.
Obesity, yeah.
Yeah. Yeah. So if you see this slide, okay. So if you see this slide, the Lancet Commission very clearly says that these are the conditions which are directly linked because of obesity. For example, patient could have headache. So there are certain patients who have, idiopathic, intracranial hypertension, which leads to headache, which is again linked with obesity. Some people have breathing difficulties, respiratory hypoventilation, and all that, which is also linked with obesity. Again, pre-diabetes, so the metabolic syndrome, classical cluster, is linked with diabetes. MASLD we discussed is linked with obesity. Again, obesity itself can lead to microalbuminuria, right? So that is also linked. Again, you could have, women with obesity can have PCOS, which we all know. Men with obesity can have hypogonadism, which also be something we know. It can, of course, lead to, diseases which could lead to reduction of the daily activity, exercise, walking, etc. Again, patients could have sleep apnea, right? Patients could have heart failure with preserved ejection fraction, HFpEF, like probably Joginder has, which also is linked with obesity directly. Patients, obesity can itself lead to atrial fibrillation, but it's more of a risk factor. But some people, because of long-standing obesity and with sleep apnea, can also have HFpEF and can also have again lead to pulmonary hypertension also. Again, some people have urinary incontinence because of obesity directly. Patients could have muscle pain, joint pain, osteoarthritis, and if you see peripheries, patient could have lymphedema and pedal edema, which can also be because of obesity in itself. So these are all diseases which are directly caused by obesity, and if the patient has any of these, the patient then gets classified as a clinical obesity, as a clinical obesity, right? So again, if we reclassify Mamta and Joginder, right, quite clearly, Joginder has clinical features which define the Joginder as having clinical obesity. So if you see Joginder, Joginder has BMI criteria which is fulfilled. Joginder has waist circumference which is above the cutoff, and Joginder has diseases which can be directly linked with obesity, for example, MASLD and sleep apnea and so on and so forth. Right. So this is a way of reclassifying Joginder. Okay. Now Indian guidelines have used similar strategy, but they've just changed the cutoff as far as the BMI is concerned, and they also slightly changed, modified the name. Instead of calling it preclinical and clinical obesity, they are calling it stage 1 obesity and stage 2 obesity. So what they've done is BMI more than 23 kg per meter square with optional any of the waist circumference, other thing. They made that optional where it was in preclinical obesity, it was mandatory. So they said BMI more than 23 without any symptoms of obesity makes it stage 1 obesity. Whereas if the BMI is more than 23 plus you have increased waist circumference or waist hip ratio or any other markers of excess body fat with obesity related issues, then you define the patient as stage 2 obesity, right? So they've used a similar criteria. Sir, any comments on this Indian criteria?
Yeah, I would like to just tell you the way definition of obesity has evolved in India in past 2 decades. Well, it used to be more than 30 when I was doing MBBS. Then we heard that some criteria came for ASEAN, and that was 27. And then for India, 25 was considered as obesity. And now we are seeing 23 being the cutoff for the obesity, probably if there is some associated evidence of fat accumulation. So, how do you feel the thing obesity definition has evolved, particularly for Indian population?
So I think, sir, now more and more we are recognizing the fact that lower BMI, you have more risk even at lower BMI in Indian patient. I think that is the crux. That is the reason why the BMI cutoff is progressively coming down a little bit, because of the fact that now we probably recognize that the risk factor start with even with BMI of 23.
23.
Right? So,
that is something we need to identify early.
Right? Yeah. Exactly. Right. So I think that is something which makes this the new modern definition for obesity from Indians also. So basically, you have to take BMI plus an additional thing. Now, what could be this additional thing? It could be just measuring the waist circumference. It could be waist to height ratio or waist to hip ratio, or you can use DEXA scan if you have facility available, or you can use body roundness indication index BRI, which is again a calculation, or you can use nowadays use body impedance, right? That machines which measure body fat. I'll tell you a little bit about that also in a few minutes.
Yeah.
So this is the this is the picture which is Dr. Anup Mishra's paper has given for measuring the waist circumference. You can very clearly see the picture in the definition here. So you have to use a non-stretchable flexible tape. The patient should be standing in a fasting state in an erect. Yeah. So the patient should be as you can see. And it is just measured above the iliac crest at the end of expiration. So this is the standard way of measuring the waist circumference, which is as defined by Dr. Anup Mishra's paper. Okay. Then you have something which is very easy to calculate, which is the waist to height ratio, right? So waist circumference divided by height. So what you do is you take the waist circumference of the patient, which is again in centimeter, and the height of the patient in centimeter.
Slide is not moving.
Okay. So is the slide visible?
We are still measuring the waist.
We share it again. Faraz, can we share the screen again? Yeah, do we have anybody from the technical team? Faraz? Yeah, can you share the slides again? Sorry.
Yes, sir. There was an issue. It got glitched, sir. I have put again on the screen, sir. I hope it is visible.
Yes, yes. Chandra sir, visible?
Yeah.
Okay. Yeah. So we take the waist to height ratio, and waist to height ratio is again very simple to calculate. So calculate the waist circumference and take the height of the patient. And a lot of studies have shown that waist to height ratio, this is what was also endorsed by the European Obesity Society last year. So they said waist to height ratio, which is very simple to calculate. If it's more than 0.5, it is considered to be positive. It's considered to be central adiposity. So your waist, if your waist circumference is more than half of your height, then you are in trouble. That is what they are saying, right? So this makes it easier to do than BMI also, because it's just a very simple measurement that you have to take. Everybody knows their height, more or less. And all you have to do is measure the waist circumference, and then based on that, you are able to define central adiposity. Okay. Moving on, you could then also use DEXA scan. And DEXA scan is again a sophisticated tool. Of course, not every center will have it. And men, the body fat percentage more than 25% is considered to be positive, and women more than 35% is considered to be positive. Generally, women have more body fat because of the hormones. So in men, even 25% is considered to be high. Okay. So if you see, this is what a typical DEXA could look like, depending on your machine, what you're using and the software which is being used. But this is the typical DEXA for body fat, which is typically shown. I'll tell you some the interpretation of some of these results as well. So when you take a DEXA scan, this one, if you see, it clearly gives you the total body fat, right? So you take the total body fat, and as we saw, if it's more than 25% or less than 25% is normal, more than 25% is abnormal, and more than 35% in women is considered to be abnormal values. If you take the fat mass index, so these are all data which is there in the DEXA. Depending on, you don't need to use all this data, but at least some of the data can be useful if you're doing, especially if you're doing research. So fat mass index is something which is useful. So again, it is kg per meter square, so it's just like your BMI, but it takes the fat mass, not just the body, right? So total weight. So it is the fat mass index. Again, less than 8.3 in men and less than 11.8 in female is considered to be normal. And then you have, this is what Chandra sir, you're talking about, the android-gynoid ratio, right? So this ratio directly DEXA scan will give you. And if it's less than 1, it is normal for both sexes. But if it's higher, it is again suggestive of, so more of android adiposity, the apple-shaped obesity compared to the pear-shaped. So of course, these terms are, we don't use that frequently anymore, but these are still relevant in today's world because it does tell us the possibility of the patient having more central fat. Again, there's something called a trunk to limb fat mass ratio. So basically, again, these are all available directly from the DEXA. So directly from the DEXA, you can get this data. And again, value less than 2.63 is considered to be normal, and if it's more, again, it is suggestive of obesity. So again, I think typically, sir, you would have seen patients who are having a lot of central fat, but the limbs are thin, right? Something like a Cushing's patient, right? So that type of obesity, right? So again, that is very high risk of patient developing complications, especially diabetes and metabolic syndrome and MSLD and so on. Then you can directly measure the visceral fat also. So in these machines, you can directly measure visceral adipose tissue. And visceral adipose mass, VAT mass, less than 500 is considered to be 500 grams is considered to be normal. More than 1 kg, right? That is 1086 gram is considered to be associated with metabolic syndrome. You can see the volume less than 600 is considered to be normal, and more than again 1025 is considered to be linked with metabolic syndrome. And VAT area also you can take, which is again less than 100 is considered to be normal. So you'll get a lot more data from a DEXA scan. So if you're again thinking of practicing about obesity, you can probably it's the same DEXA machine which you use for osteoporosis, but just the software that needs to be a little bit updated, and based on that you can get a lot more data based on that. There is another famous calculation now which has become very popular, that is body roundness index. So those who follow, we have a website called Endocrinology India. So it's called endocrinology.co.in. I put the link in the description here. So there you can use this. We have made this calculator for body roundness index, BRI. So you can see from the video, I'll just show that video. So it's very simple to use. You can use the calculate at the height, or you can use it in feet and inches. Or so, for example, I'll calculate my body roundness index. So my height is 5 feet 11 inch, and my waist circumference, again you can enter in centimeters. Or so let's say it's 100. Then my body roundness index is 4.44, and it also gives you the interpretation of the results also. So based on that, you can interpret the results based on that. Now, there's a recent study which has looked at body roundness index and the risk of cardiovascular disease, and they found that BRI less than 3.4 is normal. 3.4 to 6.9, you have moderate risk, right? Which probably I have. Body roundness index of 6.9 to 10 is definitely on the higher end, and more than 10, you have higher risk of cardiovascular disease. So more, likelihood of metabolic syndrome and cardiovascular disease. So, sir, again, in terms of, you find this any of these useful in clinical practice, or would you be,
See, the wonderful thing that you have told about, we usually talk about waist-hip ratio, just to differentiate android and gynoid type of obesity, number one. Number two, the wonderful that you told, the different quantifications that we do get from DEXA scan is really, if somebody is able to interpret all those things, that has got a lot of sense. And that would really help us in identifying people who are at metabolic risk of obesity. And yes, this body roundness index, what I could get is that we are trying to see the waist ratio in comparison to the height. And if I believe there might be some formula into it, which might be
formula which is there.
roundness index.
Yes.
So if your waist is comparatively more in comparison to your height, probably the severity of disease goes on increasing. So these are wonderful tools which will help us in identifying people who are obese and who may have clinical diseases because of the obesity.
Exactly. So I think that's that's the whole idea. Then you have this, a bioelectrical impedance analyzer, BIA, right? Which a lot of gyms and all that, but all the machines. So there are some caveats to using this, analyzers. First of all the analyzers are not standardized, right? So the machine which you're using, you should be aware that whether it's a standard machine. There are certain companies, I'll not name the companies, but there are certain companies which make good machines, which are very comparable with DEXA. Whereas there are certain machines which are just gimmicks, right? So you have to be very careful of what machine you're using. The really standard machines are quite expensive also, right? They cost can go in lakhs, whereas some of the cheap ones are easily available on Amazon for a few thousand rupees. So be careful of what machine and what is the accuracy. But having said that, if you use a good machine with a good accuracy, recently there's a study published in Indian Journal of Endocrinology and Metabolism, which compared the BIA, the body impedance analyzer, with DEXA machines, and they found that there's good congruence with good correlation between these, right? And what they also found was some normative data also for some of their patients. So they found that the body fat percentage for obese Indian, they used a definition of 25 as a BMI. They found that the body fat percentage was 36 in this group in general, male females combined, and we clearly see whether it's male or female, it's higher, right? So clearly see. Then they compared it with the DEXA fat percentage, again it was 39, so it was high. So again, in terms of comparison, they found that there was reasonably good congruence between the body analyzer and the DEXA machine also. So if you don't have a DEXA machine, probably the body fat analyzer, the impedance analysis also can be useful. But again, you have to be careful to use the good quality machine rather than these ones. So the point being, right? So I'll just summarize the take-home message. Sir, anything you'd like to add before we conclude? So mainly we're discussing today's idea was to mainly tell you about the new ways of defining obesity and understanding obesity, because now this lays grounds for a lot of therapies which are going to come this year in terms of management. And today is also the World Obesity Day, so I think it's a good time really today to discuss these points. So anything you'd like to add before we'll take some take-home messages?
What I wanted to once again emphasize, BMI alone is, correct, I can say, is outdated now, unless you do have a real assessment of adiposity. And just talking obesity, we need to understand that preclinical obesity and clinical obesity is something different. And considering obesity as chronic disease requires some or the other evaluation about adiposity and adiposity related organ dysfunction. Wonderfully summarized by you about the newer methods by which we can evaluate the clinical obesity or pathogenic adiposity, waist hip ratio, you told about roundness index. So all those things are newer ways by which we can do. I understand that DEXA scan may not be available at most of the centers. Even those BIA scales may not be available, but simple clinical tools that you have told, they are really wonderful to identify people who are having clinical obesity. And uh, whom to be prioritized for the management of obesity, that also needs evaluation. Somebody who has already developed diabetes, heart failure, somebody who is just having pre-diabetes, fatty liver, or somebody who is not having anything. So preclinical diabetes, clinical diabetes, and sorry, preclinical obesity, obesity, and obesity as a chronic disease. We can have rather, three groups.
Correct.
If I'm not exaggerating the explanation, but I believe we can have something like that, and we need to prioritize people like Joginder for management of obesity.
Absolutely, sir.
You agree?
Exactly the
Yeah.
point. Absolutely agree. So just what sir said, in terms of take home messages, we need a new way of defining obesity. And like we discussed, everybody one size fits all, typically that era is gone. You need to have multiple ways in which you can define obesity, especially looking at Indian patients who tend to have more of risk factor at a lower BMI. So obesity, remember also that obesity itself is a risk factor as well as it's a disease in itself. So that also is something which we need to understand. And way back, many years back, WHO had defined obesity as a disease. So I think we also need to consider it as a disease which needs some sort of a therapeutic approach to it. Again, if you take the BMI cutoff values, the clinical obesity diagnosis has three criteria. You should have a BMI cutoff above the ethnic cutoff. Like for Indians, we use 23 as per the again the new guidelines. Plus one more measure for obesity, for example, the waist circumference or the waist to height ratio or BRI, and some clinical evidence of the manifestations of the obesity. For example, signs and symptoms of obesity, some daily limitation of daily activity or organ involvement. And if you take the Indian cutoffs, this is what Dr. Anup Mishra's paper defines. Obesity more than 23 kg per meter square becomes stage 1, with or without waist circumference or other measurements, provided the patient does not have any complications at that point of time. That's stage 1 obesity. Whereas somebody who has more than 23 kg per meter square plus either waist circumference or waist to height ratio, which is high. Remember, waist to height ratio more than 0.5 is considered to be high. Waist circumference more than 90 in males and more than 80 in females. With obesity-related limitations of daily activity or associated comorbid conditions, these patients should be considered in terms of priority, in terms of treatment and offering therapy to these patients. So again, thank you for a patient listening, and I think there are maybe a couple of questions, so I think we can discuss that.
Okay, there is a question in chat box. Though this is a question regarding management of dyslipidemia, I would read it out for you.
Yes, sir.
Uh, can we continue in obese with high cholesterol